Hello, everyone, and welcome to our presentation today on coding and documentation, getting paid, and leveraging some of the technology and voice recognition as well as our EMR with a focus primarily on some of the updates for 2021 with the CMS E&M documentation changes. A little bit of background for those of you who don't know me. My name is Dr. Bradley Gray. I'm an osteopathic physician in the Northern Kentucky area. I've been practicing for about 10 years, the last 7 with the St. Elizabeth Physicians Group. I am one of our informatics directors. I'm a huge fan of gadgets in healthcare. I think that technology has enhanced a lot of aspects of our life, including the way we deliver healthcare. I didn't get a lot of gaming systems as a kid, so I'm making up for it now. The tools that I use primarily are the Epic EMR. We're on the May 2020 release. We also use Dragon Medical One, which is Nuance's latest voice dictation product that is cloud-based. This allows us to use a PowerMic Mobile, which instead of having a handheld microphone allows my cell phone to be a dictation microphone. Our EMR system also has a provider app called Haiku that accesses the EMR and allows us to do progress notes on the fly. It is dictation enabled. I've been using Dragon's dictation software for the last 10 years in some version or another, because when I got out of residency and went into my initial practice, we started up an EMR about 6 months in, and I realized that I did not want to get carpal tunnel doing progress notes. And so I'm going to use some of those experiences to kind of talk about where we're at today. But first, we want to get into some billing and coding updates that I think most of you will find refreshing. As many of you, I'm sure, know, CMS has been working for a long time to update the way we use billing and coding. We have been using systems that came out of the 90s, well before EMRs were around. And CMS recognized that that created a significant documentation burden on providers, and they were hoping to take the EMR out of the exam room just a little bit, allow patients to focus on that doctor-patient relationship. They called it putting patients over paperwork initiative. And it's finally some good news from CMS. Life's about to get a little easier for providers, and CMS rarely does that for us. They have simplified the outpatient E&M coding rules, and that's really where we're going to focus. So for those of you that do inpatient stuff, be aware that these rules are not the inpatient rules. These are outpatient rules. We're getting rid of bullet points. So for those who every day look at how many history of present illness and how many review of systems bullet points and how many exam bullet points and are we using the 95 or the 97 guidelines, they're getting rid of all that. They're removing the need to provide redundant information that's already in the EMR. I liken this to when we had our paper charts and all we did was initial the past medical history or the medication list or the allergies for the date of service instead of having to redocument all of that in a handwritten progress note. We never did that until the EMR. You may actually make a little more money in this system because with these changes, we are more likely to accurately code. And in many cases with some of these changes, CMS is recognizing that things that we do routinely, just because they're routine doesn't make them low complexity. And so some of the complexity stuff has gone up. Many of you remember this particular format. You may have it in a couple of different versions. Usually we kept it in a laminated card in our lab coat pocket so that we knew exactly how many bullet points we had to get to capture that elusive 99214, which is where we tried to make more of our revenue for the work that we did. You'll see that in this, there's a lot of time spent in that history, that exam, and then the medical decision-making guidance isn't very much, but a future for this actually looks a whole lot better because they've gotten rid of, like I said, the upper portion of this for history components, the exam components, and they've basically said you need to document what is pertinent for medical decision-making and a pertinent exam, a pertinent history, but they don't give any other guidance than that. And then they update the medical decision-making and time components. So let's talk about what those changes really mean. So we're going to be billing and coding now on level medical decision-making or time. We've removed the parts of the history of present illness, the review systems, the exam. This should allow us to streamline our documentation. It also allows documentation adjustments to match open notes changes, which is going to come up in a little later in our presentation on the 21st Century Cures Act, and that is cures, not cares. Sometimes we mess those up. As you can see here, the long note is a standard progress note that gets printed out of our EMR. Right next to that is what this note could be if we pulled out all the stuff that exists somewhere else in the EMR that really did not need to be imported into the note. You can see just on this visual how the ability to review the data becomes so much easier when it's much more compressed like this. This is a big slide, and we're going to spend a few minutes really kind of looking at this and going over a couple of pretty heavy components that exist in here. This is very similar to the medical decision-making slide that we have seen previously. A couple of areas that I want to point out that I think are very important. One is that you'll notice that 99211 has been removed. That level of service was so low, it required so little to do that they realized that no one should be coding a 99211. The other thing that you'll notice is that they have taken 2 or more stable chronic illnesses and moved that into that moderate level of medical decision making. That's a big step because traditionally it has been 3. And so a lot of times you would see providers trying to figure out, is there another diagnosis that could go in here so that we captured that 99214? Now we don't really have to do that. We get to say, look, they came in for their high blood pressure and their cholesterol, and that's moderate complexity. They help us define, and we'll talk about a little further down, some of these terms that can sometimes be a little confusing, such as what does a stable chronic illness look like? What does a self-limited disease process look like? Those areas of ambiguity that really created challenges for providers when trying to determine what their level of service was. And because of that ambiguity, providers typically did not want to overcode, and so we would see undercoding for things that really maybe could have been coded at a slightly higher level to be reimbursed accurately for the work that was done. In the far left-hand column, you'll notice that the numbers that exist there for 99212, 99202, 99203, 99213, on down the line, it shows that the documentation requirements for those are the same. So as all of us know, the 9920 numbers are new patient visits. The 9921 numbers are established patient visits. Because we've removed the history components for billing and coding, and we've removed the exam components for billing and coding, we no longer need to have a complete history, a complete exam, and then medical decision making for those new patients. It always used to be 2 out of 3 for established patients, and then 3 of 3 for new patients. So a lot of new patients were down coded because they came in with a moderately complex history, but we really did an abbreviated exam. We didn't do a full exam. They had the medical decision making, but we were missing that middle component. And so this was an area where you would see templates drive some of the documentation to make sure we had all of those bullet points. Some of the things that may have been documented may not have been done in the detail that we would have expected if patients had reviewed those notes or someone had audited those notes. Did we really do a full neuro exam? That kind of thing. And so those were areas where in the attempt for a lot of providers to try to make sure that their documentation met where they needed to be. So they were documenting to the code instead of necessarily documenting everything that was pertinent for the visit. It can put them in challenges with audits. So CMS got rid of that. They said, look, it's all medical decision making. When we move to the elements of medical decision making, this gets a little easier as well. So the review of results for each unique test, and a unique test is defined as an individual test or a panel. So a BMP typically has a sodium, potassium, chloride, creatinine, some of those types of things. Each one of those is not an individual test. That panel, that BMP, is a unique test. So you get a point for every one of those that you review in this window. That can be the lipid panel you reviewed, the BMP, the old EKG, the chest x-ray. You just need to document in some way that you reviewed those particular tests as part of today's visit. And usually it's the outcome of those tests. Reviewed the CMP and glucose node to be elevated, reflex into an A1C, that type of thing. For the 99214-204, that kind of bread and butter where most of us live, you only need 1 out of 3 of these categories. So Category 1 is any combination of 3 of the following. Did you review prior external notes from a unique source outside of your system, but partner's notes, if you reviewed a specialist notes, those types of things, I would say that probably counts in this window. The review of any tests. So did you look at their old tests before you walked in and saw them? Did you order any tests? And any assessments requiring an independent historian, and they go on further to identify what an independent historian is. So for pediatric patients, if you've had conversation with their parents, that's an independent historian. If you've got elderly patients who come in and their spouse is providing some of that history because the patient may have a little dementia or perhaps some other cognitive disease, those all count in this window. The category 2 is independent interpretation of tests. So if you look at a chest x-ray, if you look at an EKG and interpret that testing, you get credit for that. And then category 3 is discussion of management or tests. So if you reach out to a specialist because you've got an EKG that looks a little funny, and with our EMRs, a lot of us now have the ability to real-time compare notes with someone. They can pull up the chart, open the EMR, and you review that together, or you call radiology and discuss a CT scan report with them. That also counts as discussion of management, and that's that other category here. So you have to hit 1 out of 3 of these categories to get that level 4 decision making. Then when we move into our risk of complications, we've got minimal risk or low risk, and then we've got moderate risk. Our moderate risk examples include prescription drug management. That can be writing a prescription, that can be monitoring a prescription, that can be refilling a prescription. For many of our patients, this is the case because a lot of them are on medications. Decisions regarding minor surgery. So if we're talking about doing a minor surgery in the office, then that ups our level of decision making as long as we have some type of documentation of that discussion. Decisions regarding elective major surgery. And then the diagnosis or treatment of significantly limited social determinants of health. So a lot of our patients have things that impact their ability to follow through with the care plan. They don't have the medications. They have insurance issues. They have food issues. They have transportation issues. A patient with transportation issues who would have had a 99213 type visit, but they can't go get their medication because of transportation issues, that does increase the complexity of the healthcare for that patient, and CMS recognized that in these new updates. When we get into that 99215, that's an area that a lot of providers may not code as much because it does take a little more work to get there. Patients obviously are going to be at much higher complexity, but they went through and they helped us identify what does high complexity look like. And so you'll notice that it's one or more chronic illness with a severe exacerbation, progression, or a side effect of treatment. So if you have a patient in your office with a severe COPD exacerbation that you're having to treat with nebulizers in the office to get their oxygen levels back up, that's probably high complexity. Or if you've got an acute or chronic illness or injury that's posing a threat to life or body function, that also ends up being high complexity. So anybody that you see that you're worried about an acute MI that you're sending to the ER for further evaluation, that's a high complexity patient. DVT is another case where we may have a high complexity patient. You need to meet 2 out of 3 of those categories in our medical decision making in order to get to that level 5 documentation and coding. And then we need to have a high risk of morbidity from additional diagnostic testing or treatment. And so drugs that require intensive monitoring for toxicity. So you're talking about things like amiodarone, Coumadin, that type of stuff. Elective major surgery with risk factors. So patients who have COPD, cardiovascular disease, uncontrolled diabetes who need to have a major surgery, that's going to be a higher complexity than somebody who doesn't have those risk factors. Decisions not to resuscitate or to de-escalate care because of poor prognosis. So you're talking about those conversations about hospice care or those conversations about palliative care. That's a much higher complexity. Decisions regarding hospitalization. Even if the patient doesn't get hospitalized, when you're having that conversation about that, that also increases that level of complexity. So they did a much better job of giving examples to help us understand where we land on this chart. Some key terms were defined, including self-limited or minor problem. And so a self-limited or minor problem is now a problem that runs a defined course, a prescribed course, usually transient in nature, not likely to permanently alter health. A viral URI. If we don't do anything for these folks, the vast majority are getting better. Strep throat potentially could fall in that window, though we'll talk about that in a minute. Viral conjunctivitis, poison ivy dermatitis. We treat that a lot, but that doesn't necessarily mean that it's not self-limited. Stable chronic illness. So a problem that has an expected duration of at least a year, or until the death of the patient. So they kind of tell us what's a chronic illness. They also help us understand what stage and severity means. So using terms like controlled versus uncontrolled. For the purpose of billing and coding, stable is defined as something that meets the specific treatment goals for that individual patient. A patient who's not altering their treatment goals isn't stable if the condition hasn't changed and there's no short-term threat to life or function. So an example of an uncontrolled patient would be a diabetic. So you've got a persistently poorly controlled hypertensive patient or a diabetic patient for whom better control is a goal, but the patient's not unstable. So even if the pressures are not changed in the patient and the patient's asymptomatic, the risk of morbidity without treatment is still significant. And so just because they're not symptomatic doesn't necessarily mean they're considered stable. An acute uncomplicated illness or injury is a recent or new short-term problem with a low risk of morbidity for which a treatment is considered. There's little to no risk of mortality with the treatment. Full recovery is expected. It's a problem that's normally self-limited or minor, and this is where strep throat may fall in, but is not resolving consistent with a defined prescribed course so that we would expect. So an example may include cystitis, allergic rhinitis, or a sprain that isn't getting better, and now we need to go do something else to evaluate that. The other area where things have changed significantly is with time-based coding now includes non-face-to-face time. So for all of us who have done time-based coding for counseling, it was usually the coin phrase, greater than 30 minutes was spent with this patient today, and more than half of that time was spent in counseling over XYZ. Because we had to bill based on the time that was spent counseling. So half the visit with the patient had to be done in counseling in order to bill for that time. They said that's crazy. They recognize that there's so much that goes into a patient visit before the patient visit, during the patient visit, and after the patient visit that are all components of time. So the example that I use here is a patient who presents with signs concerning for a DVT. You spent 15 minutes in the office with that patient. You sent them for a stat ultrasound of the lower extremity. You spend 5 minutes on the phone with radiology because they called you with the stat ultrasound results. Going over that result, the result ends up being negative. They've got a little venous insufficiency. You spend another 10 minutes on the phone with the patient after the visit on the same date of service, going over those results, and the treatment plan is going to be compression stockings and elevating the legs and moving forward. The total time spent with this patient is 30 minutes, which can count towards billing. Even in the setting where the patient was only in the office for 15 minutes and they didn't have a DVT, we could still bill and code based on the time spent. It's very important to know that time spent is based on date of service. They do allow for the time spent documenting to count towards that, which is a greater motivation to get our documentation done on the day that we see the patient if we're billing for time. And so what does time mean? It recognizes the importance of non-face-to-face activities by a qualified health professional, so that can be a physician, a mid-level provider, or other. Time spent by your clinical staff doesn't count. They change the increments so that it's a little bit easier to use. They removed midpoint versus threshold, and they give exact ranges. You don't require a minimum amount of time when using medical decision making. So if you're billing based on medical decision making instead of time, then this doesn't matter. So they gave us two options to bill, and it's only one clinician is addressed. So one person per minute. So if two doctors are in the room at the same time, only one of you gets to bill for time. Or if you stagger it, then you can only bill for the time that you were there. So what is time? Well, time is the time that we spent preparing to see the patient. So most of us will open the chart, review it. Some folks do pre-charting the day of or the evening before. If you do pre-charting the evening before, you don't get credit for that. But the day of, reviewing tests. And this goes back into that medical decision making where we talk about all those little things that we've done that count towards those bullet points in the middle there. Obtaining and reviewing histories. So if you contact somebody else, then like a family member to get some further history, that counts. Performing the exam, counseling and educating the patient, the time spent ordering medications, tests, or procedures, and then Communicating with other healthcare professionals. So if you reach out to one of your specialists and say, hey, I'm sending you a patient, this is what's going on, this is the story, when can you get them in, and it's all done on the same date of service, you do get to count that time. Documentation in the EMR counts. A lot of us spend 3 to 5 to 10 minutes documenting a note depending on the complexity. You get to count that time as well. Independently interpreting test results that you didn't bill for separately. So if you do an EKG and you bill for the EKG, you don't get to bill for the time to read the EKG because you've already done that. You do get to count the EKG towards your complexity, but you don't get to bill for the time. Communicating results to the patients and family members. So when you call the patient that day because they went and they had their scan, give them those results, then you get to count that time as well. And any care coordination that's not reported separately. So if you're working with a social worker or a therapist and you're doing that kind of care coordination and you spend time having a meeting after your visit with the patient to identify a care plan, you get to bill for that time as well. Time is defined in ranges, not thresholds. So it used to be a cutoff of 20 minutes and then 40 minutes. And you can see this slide kind of shows us what those old times were. You can see here they now have 15 to 29 minutes, 30 to 44 minutes, 45 to 59, 60 to 74. My recommendation is if you're billing for time, you need to make sure that you're actually documenting how much time was spent in each component. You'll get into a little bit more trouble in the auditing world if you just randomly say, I spent 48 minutes with this patient, or 48 minutes was spent on this patient today. They're going to say, well, where did you spend those 48 minutes? And you want to be able to justify that in your documentation. You can see the time thresholds for established patients for the higher levels of service are a little bit lower. And so what does it all mean? Well, it means that the meat of your documentation should really be in the discussion and the assessment and plan for medical decision making and billing. You want to have pertinent supporting documentation in the subjective and objective components of your note. You want to be accurate, but you don't want to opine. You don't want to have long narratives, especially since we're moving towards a concept of open notes. You want to think about the assessment and plan more as a summary and discussion of the visit, something that one of your peers or the patient and family could read, know exactly what happened in the visit and what should happen next. So the acronym MEET also helps us kind of fine-tune what needs to be where. You want to talk about things that were monitored. You want to talk about things that were evaluated, things that were assessed, and then things that were treated. Let's go through a couple of examples, see if we can kind of put this all together. So an 11-year-old male presents with a 3-day history of a sore throat. Got a fever up to 101, some associated nausea, no vomiting or diarrhea. Siblings recently diagnosed with strep throat, no rashes. Vital signs were reviewed in the chart, was noted to be stable and afebrile at this time. He appears non-toxic. The posterior oral pharynx is erythematous with tonsillar hypertrophy without exudates. He's got a little shoddy anterior cervical lymphadenopathy noted bilaterally that's not tender. Cardiopulmonary is unremarkable. Skin's without rashes. We did a rapid strep in the office, and that was positive. Our assessment is going to be strep throat. Our discussion is a rapid strep screen was performed in the office today, was noted to be positive. Patient with symptoms and exam consistent with strep throat. He had 2 episodes of strep throat last year that were noted on review of his progress notes that responded to azithromycin. He's got an allergy to penicillin. We will treat with a Z-Pak. Mom is aware of the risk related to antibiotics, including potential side effects or allergic reactions, but he has tolerated this antibiotic in the past. Mom is also aware that we are treating strep throat with antibiotics to avoid rheumatic fever or rheumatic heart disease, as these are potential significant complications that can occur from this particular type of bacterial infection. They had no questions, and they'll pick up the prescription from the pharmacy. So that's our visit. That's our documentation. You can see that we've got what happened, what did we see, and what are we going to do about it. So how does this code out? Well, we have a medically appropriate history for the presenting illness. We reference other sections of the chart, such as vital signs that were reviewed and old progress notes. This information already exists somewhere in the chart, so I don't have to put it in my note. It's been reviewed. Most EMRs have a little box that say reviewed. You click that box, and now we've documented that you've done it. Most EMRs do what is called an encounter summary. So your progress note is part of the encounter, and that encounter will contain all the things that were done on that date of service, including any testing that was done and resulted, any vital signs that were put in, any updates to the medical history in that section of the chart. So all of that stuff exists when we talk about what are we going to give to an auditor. He does have some systemic symptoms with a fever. So let's look at the billing. We've got one acute problem with systemic symptoms. Our risk of complication of the problem was discussed with the family. So we know that there's some potential risk if we don't treat this particular condition. We also had medication management. So we were aware of his penicillin allergy. Penicillin is generally a first-line treatment for strep, but we're not doing that today because he's got that allergy. That adds complexity, and we discussed the overall risk of antibiotics. We ordered and reviewed a diagnostic test. That was our strep screen. And so our final code for this is actually probably a 99214 based on the new guidelines. And so strep throat is one of those that classically a lot of providers have billed as 99213s because they've said, well, this is pretty it's pretty easy for us. They come in, we swallow them for strep, we know what they got, we put them on antibiotics. Just because it's something that we do routinely doesn't mean that it's not necessarily medically complex. So for my general surgeons that take out gallbladders, that is something they do incredibly routinely. That doesn't mean that it's not medically complex. So let's look at another one. So 57-year-old comes in for follow-up of hypertension and hyperlipidemia. He's on amlodipine 5 milligrams daily. He's on atorvastatin 20 milligrams daily. His labs were completed on 7/21, showed a normal CMP and a normal lipid panel. So you'll see we referenced the date of the labs and the lab panels. That's 2 points right there. Our liver function studies were also normal, so that's 3 points. No other acute complaints, needs refills on his medicines. He's also due for his colon cancer screening. Patient had no acute complaints on review of systems. You can see that we've got a very pertinent exam. He basically looks normal. His assessment is hypertension, stable, hyperlipidemia, stable. He needs his cancer screening. And then you can see the discussion here. We refilled his medicines for the next 6 months. We ordered CMP, a lipid panel, for the next visit. So that's 2 more points in ordering a test. And we discussed his colon cancer screening and ordered another test there. So once again, we've got a pertinent history and exam for routine follow-up of chronic conditions. In this case, we only have 2 chronic conditions. And in billing, we got 2 stable chronic conditions. The results of each unique test, so we got a CMP, a lipid panel. We ordered 3 unique tests, the CMP, lipid panel, Cologuard. So there's my 2 out of 3 in that area. I've got prescription drug management because we're continuing his current medications. So from level of medical decision making, this is a 99214. Under the old rules of medical decision making, this would have been a 99213 because we only had 2 chronic stable conditions. So here's an area that we can code up just a little bit. And then here's our last one. We've got a 57-year-old male with 2 weeks of fatigue. We notice that exertion makes it worse and he gets a little shortness of breath. He's got a heart rate on his Fitbit and notice that he's running 120s periodically, even at rest. He's got a family history of cardiovascular disease, not on any medications, no recent surgeries, non-smoker, no alcohol, so pertinent history components. His exam reveals a heart rate of 135. Blood pressure is normal. The remainder of exam shows an irregular heart rate on auscultation without a murmur. Lungs are clear, no edema, neuroexam's normal. The EMR is reviewed. He had an ER visit on June 3rd for chest pressure with a negative workup at that time. EKG from that visit was reviewed by myself showing a normal sinus rhythm without acute findings. So I just reviewed somebody else's test. Last CBC and CMP in 2018 were reviewed and noted to be normal. So there's 2 more points. EKG in the office today shows A flutter. So in my assessment, I've got new onset A flutter. So I'm going to order a TSH, a CBC, CMP, a lipid panel. And I also called one of my cardiologists and said, hey, Dr. Barr, will you look at this EKG with me, make sure that I'm on track where I want to be? He pulls it up in the EMR, reviews the tracing with me, and asks that we start the patient on an anticoagulant and a beta blocker. And they're going to reach out to the patient, schedule him for follow-up in a couple of weeks. Based on his exam in the office today, he has stable A flutter. He is not having severe symptoms. We discussed possibly going to the ER for evaluation or hospitalization, but determined that that wasn't necessary at this time based on his stability. And then you can see what we started as far as medications and his post-visit instructions. This really ends up being that elusive 99215 because we've got an acute or chronic illness or injury that poses a threat to life or body function. We all know that A flutter can cause significant issues if gone untreated. We reviewed prior external notes from the ER. We reviewed tests from the ER as well as that EKG. We ordered tests. We discussed it with a specialist, and we had discussion about whether or not to hospitalize. And the patient was put on anticoagulant medication, which does carry higher risk. And so this is one of those areas where we can get to code accurately for the complexity of the patient. And a lot of providers have avoided the 5 codes because of fear of audit. But I think if your documentation is well supported, you can easily see where some of those high level 4s can move up a little bit as long as our documentation supports it. So that's an overview of some of the major changes that have occurred in the documentation and coding guidelines from CMS. Let's take a quick minute and look at the 21st Century Cures Act, technology in medicine and information blocking, as these also play into some of this. So the 21st Century Cures Act is a bill that was passed a couple of years ago by Big Pharma that loosened some restrictions on FDA guidelines, reduced some of the stringency that kind of went there. The big things that kind of came out of it are, for most of us, are rules on information blocking and data exchange. So it's how do patients get their information, how do we release lab results, progress notes, that kind of stuff. I was just listening to the news last night, and they mentioned that patients now have more access to their healthcare information based on some of these individual rules. And what does it mean? So the big thing is information blocking, and for most of us, it means that providers and health systems must provide essentially complete and immediate data to a patient in a common language they can use with apps and other EMRs whenever they wish. So the idea is the government wants to have a download my data, and this button actually comes from a government website, and failure to provide that information is considered information blocking, which can result in fines and other issues. This goes into effect beginning of November of this year. So if you have not discussed this in your systems with your healthcare providers, it's something you probably do want to be aware of. Some of the pros and the cons: this will empower patients to take better control over their health because they'll have more access to the information. It eases the development of apps that can improve patient engagement, and it fits with that consumer-driven, patient-first type healthcare model that we see in a lot of discussion. One of the cons is that we lose a little bit of control of some of that confidential health information. It's only as secure as the app. So with all the issues that we've seen with TikTok and some of that stuff, worrying about bad actors having access to information, we now take all that health information and make that available. It definitely takes the opportunity for patients to be taken advantage of based on their data. So some of that data gets out. People can be targeted based on their disease processes for, at minimum, advertising and marketing. Patients will be able to view results often before providers see them. So a lot of providers are very nervous about the fact that when things pop up in lab results, patients are going to have questions before you've even had a chance to see those results. And here's an example of the Apple Health Kit. And you can see that you can access your records. These are organizations that already allow certain things to download directly to a patient's individual file on their phone. So a lot of times we get asked, can we block sensitive stuff? Like there are things that we need time to process as providers before we go over it with the patient, and the short answer is no. The only time that you can block information is when it will cause physical harm to a patient. Emotional harm specifically is not a reason to block information, and that's outlined in the legislation. Blocking of a result can be done on a patient-by-patient basis if there's suspicion it'll cause physical harm. So, for example, on the right here, you can see the patient has a lung nodule, and the radiologist makes a comment that says concerning for malignancy. So now the patient calls you and goes, I think I have lung cancer, I saw my test. And you're like, wait, what test? Secondarily here, you've got Huntington's disease. So Huntington's disease is often a fatal condition with a shortened lifespan. And so is this patient at risk of doing something drastic now that they have this terminal condition? So what notes are shared? So typically you can expect office visit notes, hospital admission, exams and physicals, operative reports, provider notes, discharge summaries, labs pathology, imaging narratives, not necessarily the images themselves, consultation notes. What do you expect not to be shared? And keep in mind that anything in your EMR or the medical record is discoverable on a legal level and can eventually be open for patient viewing. But Things that typically are not released to patient portals are going to be staff messages, telephone encounters, anything related to sensitive behavioral health topics, or potential legal issues such as criminal cases, assault, abuse, those types of things. And so this comes back to our documentation component that we've talked about before, is what do we need to worry about with our notes? Now that we have the ability to streamline our notes a little bit and document a little bit easier, we need to make sure that we use language that is patient friendly. You want to avoid cloning notes or copying notes because there's a much higher risk of pulling things forward that may have been done on a previous visit, weren't done on this visit, creates discrepancy if patients are comparing notes. That leads into being very careful with macros, templates, smart phrases, and making sure that we don't document things that may not have occurred in the visit. Pre-populated exam templates are a common place where this occurs. And macros can be a problem. So macros made documentation easier when we were trying to get all those bullet points, but if you have a macro where you've made changes at the last visit that note, in this case, the patient was obese and had a murmur, and then we just dropped in the regular macro, forgot to edit the physical exam, the patient's going to look at that and go, well, did my murmur go away? And we don't want to create that particular disconnect between the progress notes. So let's talk about documentation best practices, and this is where we kind of get into more of the technology component. You want to use technology to your advantage. You want to pull data into your note that's concrete. So a lot of these notes will drop in vital signs, maybe some lab results or imaging results. If you've got patient-entered questionnaires or data, those are great because the patient's never going to conflict that that's not the data they put in the questionnaire. Instead of pulling a ton of lab results and imaging results, the full medical history, those kind of things, reference those sections in your note when you're doing your note. So you saw that in some of the documentation before. We referenced the labs were done on such and such a date and they were noted to be XYZ. It makes it much easier for somebody following behind you to assimilate the information from that visit. Most, if not all, EMRs denote when you have reviewed a part of the chart. So if you've reviewed a part of the chart and you've clicked a marked as review button somewhere, you've done that. That counts for that visit. You don't have to do it somewhere else. I tell folks dictate whenever possible. It's generally going to be conversational. It's easy to follow. It can be done quickly by multiple routes in many EMRs. Plan for your notes to be read by the patient. Now, a lot of us can get nervous about that, but it's an opportunity for it to be instructional for patients and other family members and other members of the care team. If we remember, patients only remember about a third of what we tell them based on studies coming out of patient encounters. So those other components may save questions after the fact and clarify what happened at the visit. If you can dictate in front of your patients, I think that's a great idea. It'll make them more comfortable with your notes, and it'll make you more comfortable with them getting your notes. And then remember, keep everything in that assessment plan as much as possible. That's going to be the meat of your note. That's the discussion, and that's where you're going to get paid. You want to leverage your patient portal whenever possible. So if you've got the ability to do pre-visit questionnaires, review of systems, health maintenance surveys, anything your patient can document for you, let them do it. If available, ask or remind your patients to update, confirm their correct medical history, allergies, medications in their portal. The less that we have to transcribe for the patient into the system, the less likely we make an error or one of our staff members makes an error. Be upfront with your patients when you're sharing notes that the note may contain medical jargon. And if there's any questions, let them know. But that's just so that you can communicate to other providers in the language that we use what's going on. And if you need to make corrections, make corrections. Build patient education into your macros. So a lot of us use macros dot phrases. We kind of fly in information. This is a great place to do that in the assessment plan. You can reference evidence-based data, update it periodically if that data changes, but this is really helpful when you're recommending a therapeutic option that may not be the patient's desired treatment choice. So a lot of patients for low back pain are recommended to begin with NSAIDs and physical therapy. When you can pull that reference there and make that part of your progress note that you discuss that, now when the patient sees that, it's not just my doctor doesn't want to do something for me, they're following evidence-based guidelines. Shift that focus to the assessment plan. So document the status of each of those diagnoses and making sure that you're having a conversation with your patients reflecting what you're documenting. So, okay, Mrs. Jones, today we've addressed your high blood pressure and that appears stable, and we've addressed your diabetes and that's currently uncontrolled with that A1C, and we've looked at your BMI and we noticed that we're still in that obese category, so we want to work on that. Those types of things will make sure that things don't end up in the note that the patient was unaware of. A lot of times we'll drop things in that exist, such as stage 3 chronic kidney disease. That's really a lab diagnosis. We may not have discussed it with the patient. It led to that elevated medical complexity, make sure that your patients are aware you're putting those things in there, because they will absolutely question you on that. Document the treatment for each of those diagnoses, especially if you've made changes in medication, that type of thing. Be very careful going forward about negative statements when a positive statement will convey the same information. So many of us would say a patient continues to be non-compliant with meds and recommendations. We may want to start to soften up the way we have those conversations, the same as we would with our patients in the exam room. Based on today's evaluation, it appears that there are opportunities to be more consistent with medications, and we've reiterated that the care plan recommendations are in the patient's best medical interest. It says the same thing to any other healthcare provider who is looking at this progress note, but it is less likely to upset our patients and more likely to engage our patients, which is really where we're trying to go. And then where's our technology kind of taking us? So I've talked about using dictation. That's what I use. There's also, it uses natural language processing. So it hears what we say and it types it straight out. There is natural language processing scribing. Nuance is a company, as well as DeepScribe, all have tools where an ambient listening device, such as a cell phone, can be turned on in the room. The provider has an exam with the patient, has a visit with the patient, does all the stuff, and just basically talks their way through it, never touches the EMR. And the natural language processing that occurs in the cloud 3 or 4 hours later kicks back a full medical note without the provider ever actually dictating. They just go on about doing their regular visit. A lot of these companies have natural language processing voice assistants, and so you're able to say, hey, EMR, show me the last chest x-ray. Hey, EMR, go ahead and order amoxicillin 500 twice a day. And so technology is really advancing and integrating into our exam rooms to put us back in contact with our patients. So be aware of that and try to follow that closely. So how do I approach it? When I do my patients, it's I kind of say the old becomes new again. Dr. Laurie Thomas is an ENT in Winchester, Kentucky, and I think that he is retired. He may have even passed now, but he took care of me as a kid. And one of the things I remember is he had an old voice recorder in his pocket, and then the old white lab coat, and he would pull that out, and in what I think was a Scottish accent, would look at my mom and click the button and start talking and say, Bradley is in today and he's doing good with his hearing and his ears look fine, and he would go through and look at us while he was telling the story of that visit, and then that would go to transcription. Doing things similar to that really can engage your patients. If they find it often very amazing, especially if you're using voice dictation software and it's transcribing on the computer as you go. When you get in the habit, you only do it once. It improves communication with your patients because it tells them that you've heard their story because you're repeating it back to them. Gives you the opportunity to pause, nod, and go, does that sound right? It also allows you to give instructions in the room that the patient hears they're going into the chart. And I find that when patients hear me put instructions in their note, they tend to pay more attention to that. They tend to recognize that more. And since they're going to get this note anyway, that makes this an area where I can continue to reinforce some of those positive changes. And I think that with the new focus on medical decision making and time, using these types of tools will allow providers to have better notes, better patient satisfaction, and hopefully, if you can integrate it into your regular workflow, less after hours work. And that concludes my presentation. Are there any questions?